So moving on to our next question, let's change our focus from the perioperative setting to the postoperative setting. So after patients get surgery. Recently, RTOG 0920 was published, and this was a phase 3 trial that asked an important question. For patients who have intermediate risk disease, they were randomized to receive either radiation therapy alone or radiation therapy plus cetuximab following surgery. So, Dr. Chen, first off, can you explain what intermediate risk disease means and how does this differ from high risk and low risk disease?
Yeah, thank you for this question. It is very important for us to distinguish the level of risk of recurrence in patients who have had surgery in head and neck cancer. And we have known that, as Dr. Trivedi mentioned before, the treatment outcomes for this group of patients are somewhat suboptimal. And from a long time ago, we have been trying to incorporate more systemic therapy in this patient population. And there were several large randomized controlled trials, both from the United States and from Europe, that showed that there are two risk factors that we categorize as high risk. Those are positive surgical margins and extracapsular extension in the lymph nodes. And in addition to those, there are additional risk factors based on the surgical pathology that we categorized as intermediate risk, and those include close surgical margin, large tumor or large depth of invasion, perineural invasion, lymphovascular invasion, or basically tumor in the surrounding nerves and lymphatic channels, as well as lymph node involvement. So the patients with those risk factors, but do not have high risk factors, we typically recommend treatment with postoperative radiation without concurrent chemotherapy.
Right. And Dr. Trivedi, many people thought cetuximab was falling out of favor. How have the results from RTOG 0920 changed your current practice, if at all?
Yeah, this is a really good question. So, as Dr. Chen mentioned, right now we are challenged when it comes to patients with intermediate risk disease with trying to balance the risk of disease recurrence and potential side effects of giving more treatment. Based on this study, I think that adding cetuximab to radiation may be an option for this particular population, but I do exercise caution given that this study didn't show an overall survival benefit. So despite doing this treatment, in the long term, there was not a benefit in terms of how many patients survived with this cancer. So in terms of my practice, it doesn't really change because I'm also worried that there was a high rate of particularly grade 3 and 4 adverse events in the population that received cetuximab.
Yeah, I tend to agree with you. And a brief follow-up question, Dr. Trivedi. There are many new agents targeting the EGFR pathway, and many of these ongoing clinical trials will exclude patients who have received cetuximab previously. So what's your advice to patients who may qualify, their intermediate risk, and thinking about the addition of cetuximab with radiation therapy after surgery?
Yeah, well, I'll always offer them this treatment. We'll talk about it usually at length. And I think for most patients, the right decision is to hold off on cetuximab, patients with intermediate risk disease. We always hope that they do not have disease recurrence, but if they do, I think having EGFR targeted therapies in later lines of treatment is something that can be very useful.